And I think when we first talked, I think when I came here in Toronto about 10 years ago, we were quite interested at that time in translating some of the high frequency work to clinical practice. And that took probably 10 years to make it to make it happen. But I'm very happy to with the developments, and this is going to have a major impact on what we do. And to illustrate that, I'll give you some examples on how you can actually apply that in clinical medicine as well, and what we hope to be able to do with it. As a disclosure, I won't talk about nanoparticles, or so we're still looking at bigger structures. So there are a couple of things, and I want to also link it to some of the other work we do, because they're closely linked, and that's the high frame rate work. And you alluded to that, so I'll give you some of the potential clinical applications of high frame rate work and how that could be applied in clinical medicine as well. I don't need to introduce anymore the use of high frequency, but it's good to remind you what the limitations are when you apply it in bigger animals like small babies. Even premature babies are much larger than small mice or rats. So the penetration, and it's obviously related to the frequency of the probe, and that's some of the penetration depths I put into that slide. That gives you some of the limitations we're facing as well when we apply it clinically, because you cannot scan very deep. You have very high resolution, but obviously you cannot scan very deep. So that's where I think, and here you see some of the developments, and the Vivo MD is now approved for clinical use, and we have been using it in our environment. We're mainly using it for research right now in our environment for the last probably 6 months. So what we're using it for, I can illustrate, is mainly vascular imaging, because the vessels in the kids are very superficial. So you don't need the deep penetration to actually see the vessels. The big advantage, and that's work we did actually a couple of years ago with a research fellow from Finland with the older types of machines, but still the data are very similar to what we see on the Vivo MD, because it doesn't make any difference. And what you see is that you get much better resolution of the vessel wall, because we're mainly interested in looking at changes within vessel walls with different types of diseases, and use that as early markers for cardiovascular disease in kids later on, and to look at some of the effects of treatments we're offering to kids. Now for children especially, you need very high resolution to see those details within the vessel wall. And you see the differences and the better resolution with the higher frequency. And this is true for, this is a carotid, the common carotid artery in a teenager. So I'm not talking about small babies, this is a teenager, where you can also use those higher frequency probes, because the common carotid is quite superficial, so you don't need the high penetration. But you see the difference in resolution between a standard vascular probe that is currently used in clinical, or was used in clinical practice, because we switched over to the high frequency probes, because it's obvious that you have much better spatial resolution, and you see the details of especially the intermedia and even the adventitia much better on the high frequency probes. We played around with it, and this is a vessel with 55 megahertz in a preterm baby, where you can have very high resolution of the vessel walls. And we're currently studying the effect of, for instance, prematurity, intrauterine growth retardation on restriction on vessel development in premature babies. So we've validated this comparing to vessel histology, and to see what the different images we saw in the ultrasound images corresponded to in histology. And we looked at different types of vessels, and we found in the muscular arteries, you have like a triple line pattern you see in the vessel wall, which corresponds to different layering in muscular arteries compared to elastic arteries. You see when we use the high resolution image, we have a double line pattern in the elastic arteries, which corresponds to what we see on histology as well. Then we started to looking at the correlation between histology and actually intermedia thickness measurements. And you see that if you use higher frequency probes, you come closer to what you find on histology compared to what you see in a 12 megahertz probe is the type of frequencies we were using in clinical practice. So you see that there's a big advantage and of using higher frequency to measure IMT, because it's much more closer to the truth, because you have a much better spatial resolution. We use that because now we know that we can measure accurately intermedia thickness in children. We use that to look at what happens when children grow up with vessel wall structure. What drives actually a vessel development in kids? So this was a study where we recruited about 220 kids, where we did measurement of the different vessels, and we measured the carotid, the radial, the brachial, the femoral, the tibial. There were a lot of, I think, a lot of measurement. That fellow did an incredible amount of measurements. I think about 30,000 measurements, and we obtained in the kids. So then we looked at what drives actually vessel wall development over time. And what we saw is that what really grows over time is especially the intima media, and especially the media is when the kids grow, the arteries become more muscular. So there's muscle that grows, that relates to growth in the kids, and that relates to blood pressure. Because as we grow, blood pressure increases, and we could find a relationship and association between blood pressure and intermedia thickness during growth. So the arterial wall thickening with age is mainly due to intermedia thickening, and we think it's mainly related to muscular. And this growth is definitely more pronounced, as you would expect in the more distal arteries. Then we said, we now know what the normal pattern of development is. Can we apply it? Can we measure differences in kids who have actually abnormalities? So we started looking at different types of diseases, and this was from a clinic run by Dr. McCrindle in our division, who looks at children with obesity, and especially obesity associated with metabolic abnormalities or lipid abnormalities. So because our hypothesis, if there are changes in intermedia thickness, it's going to be especially in kids who have lipid abnormalities. So we started doing measurements in different arteries, also the carotid artery, in kids with obesity, and we could recruit lipid abnormalities, metabolic syndrome, could recruit like 58 patients. And here again, even in the obese kids, we could get high resolution images in almost all of the kids that were included. And there we could see that especially in the carotid, you could find at early age already significant changes in carotid intermedia thickness with no changes in the more distal arteries. But that suggests that you have, in obese kids with lipid abnormalities, you have some changes in vessel thickness already, which suggests that there is potential for early atherosclerosis. We looked further because we were fascinated by the idea that blood pressure drives vessel wall thickness. And we have a disease called coarctation of the aorta, which is a narrowing on the aorta kids are born with. And that results in high blood pressure, especially on the right side of the body. The right side of the body, you will have higher blood pressure compared to the left side of the body. And we started looking at comparing kids with coarctation, stented coarctation, different types of coarctation. And we looked at vessels on the left side of the body versus right side of the body. And using high resolution scanning, we indeed found differences. We found in vessel wall stiffness, and we found also differences in carotid IMT, which was measured on the which all are pre-correctation. The IMT thicknesses in the left and right carotid were thicker compared to normal. But then if you look at differences between the right and left arm, you could see that the vessel wall thickness in the left arm was lower compared to vessel wall thickness on the right arm, the IMT, because the left arm is at lower blood pressure compared to the right arm. So it meant that we could pick up differences that made sense and related to pathology. So we found a closer relationship actually between regional IMT measurements and regional systolic blood pressure measurement, again suggesting that indeed vessel wall remodeling is related to blood pressure. So because we had already that evidence, some evidence, because it's an association during normal growth and development, but here this is in pathology where you have the expected differences in vessel wall thickness that are related to blood pressure differences. Another thought, you move that further, we wanted to look at patients who have a very abnormal circulation. Fontan patients are patients that are actually born with one single ventricle, the univentricular hearts, which we palliate by bringing blood to the lung circulation by directly connecting the systemic venous circulation to the lung circulation. So those kids live in a passive flow through the lungs, and we use the single pump to pump blood to the body. This is called the Fontan circulation, very abnormal circulation, which is characterized by chronic low output. And we were interested to see on how chronic low output results in vessel remodeling, which you could actually detect differences. And interesting, all the vessel wall thicknesses we measured in Fontan patients were thinner compared to normal patients. So there was vascular remodeling that occurred in those patients, or abnormal growth of vessels that occurred in these patients, because to prove that it's growth related, we would have to have longitudinal data, something we are now trying to obtain. Because it would be interesting to see what actually develops different in those vessel walls compared to normal kids with a normal biventricular circulation. But it's very interesting to see that the arterial walls are very significantly thick. And this is because the veins in patients with Fontan circulation are also under higher pressure, because the systemic venous pressure is the driving force for the pulmonary circulation. The veins are at much higher pressure. We looked at veins in using high resolution imaging, and this is a fascinating image of you see a valve in a vein, and we measured vessel thickness in veins, and what you see is that those veins become muscularized because they're at higher pressure. You have an increase in thickness of the venous structures, and the venous structures actually become more muscularized in those kids. So there's vascular remodeling that occurs, also related to wall stress probably within the veins. So this is fascinating, innovative work looking into vessel remodeling. So there are novel clinical development we're trying to do now with this technology, look at clot visualization. And I think it was some images showed already looking at microcirculation, especially with the high frequency probes. You really nicely see the microcirculation, for instance, in the extremities. And we have a lot of interest in brain imaging and brain vascularization. We also try to do some intraoperative imaging with the system, especially coronary artery system. Something I briefly want to, this is another type of development. We're very active in because kids have higher heart rates compared to adults. So higher frame rates would be of interest for us. So high frame rate imaging and ultra-fast cardiac ultrasound really has an advantage. And you know that the traditional beam forming takes time. It takes a while to get all those beams to tissue. If you could send a plane wave through the tissue, that goes much faster. So you can obtain much faster high frame rate imaging. We have been working with high frame rate imaging over the last couple of years is developing blood flow imaging, because blood flows much faster compared to movement of tissue in the heart. So to see blood flow, you have an advantage for having high frame rate imaging. And for myocardial imaging, and I'll show you an example at the end. So we've been working together with a Norwegian group to using high frame rate imaging for blood speckle tracking. Instead of the idea was, if you can track the myocardium and speckle track the myocardium, why can you not speckle track the blood flow? You need high frame rates for doing that. So the first thing you needed to have was high frame rate imaging. You do some filtering and then you can do speckle tracking. And that works pretty nicely. And it's much better compared to the traditional ways of blood flow imaging, which is in the adult world you can do particle imaging, velocimetry, which however requires contrast injection. And for application in pediatrics, no kids can volunteer to have an infusion of contrast. So and contrast is really off-label. So and there's another method that was developed by another company that uses more modeling. So this is the current state-of-the-art blood speckle tracking imaging that's now commercially available. It took also 6 years to develop it and to get it on the machines. But you see that you can, and this is also in the higher frequency range, because it's pediatric only for now. This, with proud I must say, it's the first clinical application in ultrasound probably developed for children first. Which is quite remarkable. So you can really speckle track the blood flow within the heart and the blood vessels, and we can do a lot of stuff and calculations with the speckle tracking imaging. So we've been validating it in vitro and in vivo as well by using it together with traditional ways of Doppler measurements. So we're looking at to look at vortex flow, and just a few clinical examples. This is, for instance, you can look at this is a patient after tetralogy of Fallot with a dilated right ventricle, where you can see really abnormal vortices within the apex of the heart. And that's exactly where this is a patient with regurgitation coming from the pulmonary valve, where the collision is of blood flows. And you can do this. If you want to do this in the cardiac MRI, that takes you 25 minutes to obtain 4D flow images. This takes us a few seconds to acquire this information. And we're also working on 3D. In the left ventricle, you also see abnormal vortex formation using speckle tracker imaging. And we're now developing analysis tools for energy loss calculation of pressure gradients, and automated vorticity analysis, which definitely will have a lot of applications in clinical practice. You really, and if you use it in clinical practice, you come across a lot of surprising findings. This is like abnormal blood flow directed in patients with hypertrophic cardiomyopathy towards the septum because of an abnormal mitral valve orientation. A final thing we're doing is shear wave imaging. Shear wave imaging, because we're in pediatrics, we don't have a method for looking at diastolic function in children. We're very limited using the traditional methods for assessing diastolic function in kids, and we would like to have a technique that directly measures tissue stiffness. Now, shear wave is an interesting concept. If you put energy on a tissue, you can generate a shear wave. Like when you put your finger on a water surface, you see those shear waves. Now, those shear waves, they propagate with a velocity that is directly related to the stiffness of the tissue. The stiffer the tissue, the faster they're going to move. So you can use shear wave velocity measurements. Been applied by a group in France, in Paris, has been working on looking at shear wave imaging in different types of cancer, for cancer diagnosis, and liver fibrosis, where it's been applied. But you can also apply it to, in cardiac application. And this is the Mayo Clinic group that has done some shear wave imaging in kids. in applying a pulse and looking at the speed of propagation within the tissue. And I could measure shear waves, and a group in Paris have now shown that if you use it in kids with hypertrophic cardiomyopathy, the shear wave propagation is different from normal controls. This is in myocardial infarction, where it's been used for distinguishing between fibrotic myocardium versus non-fibrotic myocardium. So for pediatrics, again, because we don't want to put a pulse on the tissue. So our group has now been working the last few years on can we use natural shear waves within the heart, because I'm used to listening to the heart. We have the heart sounds. When the valve closes, that's actually a mechanical wave that transmits through the myocardium. So our idea was, why don't we look at natural shear waves instead of putting a pulse on the tissue and then look what's happening to the tissue. So, and together with the group in Rotterdam and also the Norwegian group, we've been looking at natural shear waves. So can we detect them? And indeed we can. You can look at shear waves when the aortic valve closes, and you can look at shear waves when the mitral valve closes. So you can actually detect them quite nicely. And they're different in velocity because they occur at different stages within the cardiac cycle, where the myocardial stiffness is different. So we had expected them to be different. Can you even, this is the first application in humans done in Rotterdam, and you can even see that they're different in patients with different diseases, both the aortic valve and the mitral valve. And this is work we have been doing with the Norwegian group, where we looked at further in detail, because we go at very high frame rates here, and it's in 3 dimensions. So we're capable now of generating more than 1,000 frames per second in 3 dimensions. So that's not bad at all. And what you can see is that we have different shear waves that occur during different parts of the filling cycle, even within the heart. And one of the most reproducible one is the one that occurs during atrial contraction. That surprisingly generates a very reproducible shear wave within the myocardium, which allows us to actually measure cardiac stiffness at the end of diastole. I won't go into the details, but I'll just show you. This is in 3 dimensions, where we now have you're seeing 35 milliseconds of a cardiac cycle, where you see the shear wave propagation in 3 dimensions within the heart of the atrial wave, the atrial contraction wave within the myocardium. You see how fast it moves, and that we're currently capable of measuring it. So it's exciting work. We could also demonstrate that relates to cardiac stiffness. So it's a very promising technique to investigate tissue properties, and will generate new insight into tissue characteristics. So those combination of those new technologies will offer us new diagnostic capabilities. And we're grateful that at least Visual Solid has worked on making a clinical machine that we can now, we have easier access. We don't have to go through Health Canada begging for approvals to do studies in kids. We can just apply the technological development in clinical practice. I thank all the people who have been working with us over the last couple of years, getting all the validation of the technologies. And I think the future of ultrasound is not only high resolution, high frequency, but also high speed. Thank you for your attention.